This video will provide an introduction to implementation science. Our objectives are to define implementation science and compare it with clinical and intervention research, distinguish between different evaluation approaches in implementation research, namely process, formative, and summative evaluations, describe the rationale for adapting evidence-based interventions, and finally discuss how to use a framework, specifically the REAIM framework, to design and evaluate an implementation strategy. We talked already about evidence-based interventions earlier in this module. And just as a reminder, these should be research-based with a theoretical foundation and evaluated using rigorous study methods. They should benefit participants in important and specific outcomes using valid measurements, and they should have demonstrated efficacy or effectiveness, and efficacy is in ideal settings while effectiveness measures the outcomes in real-world settings. So implementation science is a field that's separate from epidemiology, but it's very much connected in the sense of trying to intervene to improve population health. This definition here comes from Eccles and Mittman in 2006, and they define implementation science as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practices, and hence to improve the quality and effectiveness of health services. So a lot of this work has come out of the VA. And just as a reminder, an intervention is an initiative, manipulation, or change that is going to be introduced, while the implementation strategy is a larger integrated package of the intervention and the approach that's designed to enhance the adoption of that intervention. This quote from Bauer says that the crux of implementation studies is their focus on evaluating the process of implementation and its impact on the evidence-based practice of interest. So this again highlights the fact that we're not looking at whether or not an intervention works. We're instead taking interventions that already have an evidence base to support their effectiveness and trying to roll them out into new settings. Here's some more examples to kind of drive this point home. On the left side in this table, we have examples of intervention research questions, and on the right side are implementation research questions. So, for example, we might want to know whether providing ART prescriptions for uninfected partners of people who have been diagnosed with HIV is effective in reducing HIV transmission among these serodiscordant couples. So that would be an intervention delivering ART to uninfected partners. The implementation science research question would be, how do we improve uptake of available prevention interventions by couples where they are serodiscordant? This table, also from the Bauer article, shows some more examples of differences between efficacy, effectiveness, and implementation study designs. I won't go through all of them, but this is here for your reference. So when we do any kind of implementation study, we need to evaluate it. There are three main types of evaluation. The first is a process evaluation, which just describes the characteristics of the use of the program. So we're not trying to change the intervention as it's happening. We're just documenting the process as it's occurring. A formative evaluation, on the other hand, is similar to process in terms of the measures that you might take, but the point is to adapt and improve the process as you're going through it. So adaptive trial designs or smart trial designs use a formative evaluation approach. And then we have summative evaluations that happen at the end of the implementation process, and this is designed to evaluate the overall impact of the program, often in terms of cost or economic impact. So here's an example of a formative evaluation. This was of a implementation study designed to introduce brief alcohol screening in primary care. And so as the program was being rolled out in a VA healthcare system, the researchers conducted qualitative interviews to identify barriers to implementing this alcohol use screening. And so for the example, the first one was a lack of time. A quote from one provider is that, "I don't have time for this. Patients aren't coming in asking to address their alcohol use. I'd be lucky to have 5 minutes to discuss it." So some of the changes that they made during the rollout of this implementation process were to condense the educational material, so cut down on the time required, and make materials available through a link in the computerized record that the provider would already have open, so that cuts down on the time of finding it. And then finally giving some evidence that brief conversations can reduce patient drinking levels, so they don't need to spend 5 minutes necessarily discussing it. So again, formative evaluation is just using information collected over the course of the rollout of the project to make it better. A major step that we often need to take in implementing interventions is to change them. So as Dan Schroeder says here, without adaptation, interventions usually come to a setting with a poor fit. In adapting an intervention, it's important to be able to distinguish between what might be core components of the program and then the adaptable parts of them. Because we don't want to lose the evidence base. We still need the intervention to have the evidence that it will be effective, but we also need to make sure that it will work in our own setting. So for example, if there's a clinical reminder that's the intervention being done, the reminder still has to pop up for specific sets of patients or characteristics. So that's the core part of the component of the intervention is the reminder itself, the reminder to the provider. However, when it pops up or who sees it, the nurse versus the primary care provider, for example, could be modified. So that might be the adaptable part of the intervention. The challenges, as you might expect, are that it can be really challenging to identify these core and adaptable components. It's rarely tested in trials. In other words, there are very, very rarely different versions of the intervention tested. So you might contact the original research team to help you identify which components could be adapted. You could look back at the theory that was used to develop the intervention to determine which parts could be changed. Other people may have made modifications already, so it's worth looking at the literature or asking peers or others about whether they've adapted the program. And then you could also get advice from relevant experts or stakeholders. It's worth noting that some people think that you really do need to have complete fidelity to the original evidence-based intervention, and so adaptation shouldn't be made. So if you do want to make changes, it's important to have a clear rationale for why you need to make changes, pilot test it if possible, and just note that if you are working within the realm of implementation science, it wouldn't be seen as unusual. So going for funding from an implementation and dissemination grant would be one way to circumvent this potential issue. There are models out there to guide adaptation. One of them is the method for program adaptation through community engagement, or the MPACE model. And the idea here is really centered around this issue that we just mentioned, that it can be difficult to identify core and adaptable components of interventions. And the MPACE model incorporates suggestions from program participants, from the population where you're intending to implement it, and make changes based on their feedback, along with content experts and other stakeholders. The goal of this was to develop a clearly articulated set of steps for the process of adapting an evidence-based intervention, with a focus on identifying population differences and then deciding what to change based on those. So here's a schematic of the MPACE model. So you start with an adaptation steering committee, then implement the unadapted program, get feedback and evaluations from participants in that unadapted program, summarize that, return it to the steering committee for them to adjudicate and make changes, and then you have your adapted intervention that you would go forward with on a full-scale implementation project. It's also helpful when doing an implementation study to use a framework. It can help you clarify your goals and objectives, differentiate the stages of the implementation process so that you have a more linear structure, but also they can allow for feedback loops. A framework can also help you identify which parts of the process you would want to measure, and it enables you to consistently discuss the implementation process. So they provide a common language, clearly defined constructs. There are lots of frameworks available to use in implementation science, but one of the most commonly used ones is shown here, the RE-AIM framework. RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So this is considering how are we reaching the people who need this intervention? Who are we reaching with it? How effective is it? Is it working within my population? How has it been adopted? What is the organizational support like or lack thereof? How are we implementing it? Are we having fidelity to the original intervention strategy? And then how are we incorporating it so that this really does become part of routine practice? So the maintenance part is all about sustainability. Here's an example of applying the REAIM framework to a Walk Kansas intervention program that was statewide. So the reach part would be measured through basically descriptive epidemiology. So participants were more often women, more active and older than the general adult population within the counties where they resided. The effectiveness of the program was indicated by the fact that inactive participants at baseline had significant increases in moderate and vigorous activity, and they sustained this for 6 months after the end of the program. Adoption would be measured by the uptake of the program. So in the first year, 48 counties in Kansas adopted the program, and by the end of the 5-year project, 97 of 105 counties, or 92%, had adopted it. In terms of maintenance, 76% of the counties offered the program to residents for 4 of the 5 study years. So this is the one piece that's missing here is the implementation fidelity piece, but that would be something that would be possible to measure. And the conclusion based on this data is that Walk Kansas is effective, has a broad reach, and enables participants to maintain increased activity over time, and it shows promise for broad adoption and sustainability. Within implementation science, it's possible to use both quantitative and qualitative data. Often we see studies that use quantitative measures through surveys and administrative data, for example. Qualitative approaches vary widely. Interviews and focus groups are common. It also might be possible to use photo voice, an approach in which participants are given cameras to document their experiences, or to do observation where researchers are watching how the implementation process proceeds. Quite frequently, you see mixed methods approaches where quantitative and qualitative data are combined to give a more holistic picture of the implementation process and to be able to evaluate it. Study designs also vary across implementation studies. So it's possible to do randomized trials, the kind of standard parallel group designs where we're comparing a treatment and control group, although adaptive trial designs are quite common so that we're changing delivery over the course of the trial based on preliminary data. There are also a number of quasi-experimental study designs, particularly interrupted time series, that are used in implementation studies. And an implementation or an interrupted time series is really looking at a trend in experiences over time and then interrupting that trend with this new intervention. Hybrid effectiveness and implementation designs are also relatively common. So this is where you might look at evaluating the implementation strategy, which would be the main aim of an implementation study, but you also might want to make sure that that intervention still has the impact or the effectiveness that you expect to see on the health outcome. So that's why it's called a hybrid design. You might reevaluate the effectiveness while also looking at the implementation approach itself. In summary, implementation science seeks to study the integrated package of the intervention and an approach to enhance the adoption of the evidence-based intervention. Frameworks and approaches exist that focus on this implementation process, including adapting the interventions and implementing the interventions.